Cervical myelopathy is a rare but potentially significantly life-altering medical condition, which can come with quite difficult conversations. So on this episode of Clinical Communication, I'm joined by Dr. Ben Davies, who is a neurosurgeon and also academic researcher into cervical myelopathy. And on this episode, we're discussing how to discuss the diagnosis of cervical myelopathy with patients, how to discuss the management options with them, and setting expectations for the long term. If you find this useful, then please do go and share it with others. Please do subscribe. You can find Ben on LinkedIn, and his charity is myelopathy.org. You can find me across social media at BYBrowPhysio. Thank you for watching or listening, and I'll speak to you soon. Why myelopathy? Why did you pick it? Of all the options you could have picked, even from medical school and into neurosurgery, what made you pick myelopathy?
So I think it's a bit that myelopathy found me in a way. So I came to Cambridge 10 years ago now, and I applied to what's called an ACF, or an academic clinical fellowship, and these are dual specialty academic training programs, and there aren't that many. And to be honest, I came a bit by accident. I was hoping to stay in Manchester where I was before, but the applications are the same wherever there are jobs. So it made sense to sort of increase my chances of success. So I applied to Manchester and applied to Cambridge. Didn't get into Manchester, ended up at Cambridge, and you sort of come, I guess, recognized as somebody potentially quite capable, but I hadn't yet got a sort of direction of travel in what I wanted to do. Um, I knew that really I was trying to look for a problem that I could sort of dig my teeth into across my lifetime, my professional career, hopefully something that I could really make a difference in. And what sort of happened is that you had the various academics in the department sort of pitching to you because they saw you as, some potential labor.
Yeah.
And one of the people who pitched to me was a chap called Mark Cotter, who's still here now and was then a final year trainee and is now a consultant spine surgeon amongst many other illustrious things. And he pitched me the problem of myelopathy. And as I started to look at it, what I saw was a big problem, a huge population of people potentially affected. Really poorly researched. If you looked at the research that was going on, it was almost exclusively about the type of operation that should be done, which really missed, huge swathes of problems that were clearly out there. And it sort of became apparent that there was going to be some very simple things that could be done to make a really big difference, as also some sort of moonshot, sophisticated science around regenerative medicine. So it was something that could really satisfy that lust for a problem to leave one's mark on, make a big difference, and have some things that you could solve as well as some things that may or may not come off in the long run.
And it was 10 years now, you said. And you're still. And what's kept you interested? Is it all those options and things there? Is that what's kept you interested?
I think the problem's still unsolved, Ben. So it's a constant journey, and I think we've done lots of great things. We founded this charity, myelopathy.org, which has become a bit of a rallying point for global interest. We've really expanded the research community outside of surgeons, really integrated all the different specialties that need to be involved. But it's still small, it's underfunded, and it needs sort of gentle nurture. I think it's a bit like that sort of first seed that's germinating on that that plant on the side, which you keep forgetting about. Every time you neglect it, it wilts and it starts to fade again. It hasn't quite got that sort of self-sustaining energy yet. So problems still to be solved. And I think like in most science, you solve one problem and you find 10 more. So it's unfortunately, I think it's going to be a lifetime plus of work.
Why is it? Why do you think that is? It's become less, it's not as potentially popular as the other branches of
Yeah,
neurosurgery.
I think a great question. I think it's a question we ask ourselves very often. I think multifactorially, it's not a very sexy condition in a sense that, it's often what's more common in people who are a bit older. I think for people, old age conditions do much poorer. It's not the sort of like cancer or children or, young Superman struck down off his horse type events that do have a huge philanthropic base behind them. It's lacked, I think, a recognition. The naming's been an issue, which we've corrected in the last few years to standardize the terminology. But, you had about 20 different names. People were talking about all sorts of different things. And then I think you had a real negativity about what could be done about it. If you went back to the 1990s, treatment was really a sort of last hurrah, last resort. It was really held back. Surgery, it's, the sort of the idea was it's incredibly risky, doesn't really help. And so we didn't do much of it. And so you had this sort of like experience of these people being disabled, whatever you did, and languishing around, then I think there was a lack of interest. And really, since the sort of early 2000s, there's been a sort of momentum towards that recognition that surgery can be much more effective. And my big thing now is that the easy win is that surgery is potentially curable if we give it early enough, and
Mm.
that's really the mission that I'm on, to try and improve diagnosis, accelerate diagnosis, because then this disease, this disability that we see, really goes away. And perhaps I should just articulate it, because I'm sure some of your listeners have awareness, but not that much awareness. But this is
Totally.
essentially a slow motion spinal cord injury. It's sort of wear and tear in the neck, compressing the spinal cord, and you get this sort of slow disability, which really looks like accelerated aging. So you get a bit clumsy in your hands, unsteady in your feet, your bladder's not working so well. You can get pain, quite a lot of neuropathic pain. But the presentation's a bit all over the place, A, because it's happening very slowly, but B, because the pattern of symptoms is different from each patient, and it can wax and wane a little bit. So the pickup is very, very late, not just in people coming to professionals, but professionals working out what's going on. And, we're seeing them, 3+ years down the line, when really the spinal cord is irreversibly damaged, and the surgery is going to stop things getting worse, but the uplift isn't really there. So we have this huge burden of disability, dependency that follows, even so with our surgery today. And what we're trying to work on is, if we can get that earlier, you think about a bit more like stroke. So the
Mm.
1950s, stroke care was very much despondency. You've had a stroke, you languish in a ward, nothing happens. You fast forward 50 years, and we've now got early detection, prophylactic treatment. We've got treatments now that will restore somebody to complete normality, and that's the sort of journey we're trying to push myelopathy on.
Mm.
And it's a work in progress.
Preventable?
I think it's the preventable. I don't think we can. That's a good question. So can we prevent it occurring? I think that's going to be a difficult. So I don't imagine that scenario.
Yeah.
I do imagine a scenario where we can react to it in a way that we're still in that window where we can reverse the disability. That's the
Mm.
thing, because the therapeutic window is quite wide, probably, it's months. But the more problem is we're currently managing it in years.
Yeah. Yeah.
So if we can get it down to months, then we're going to make big gains.
And is the decisions, because there's the mJOA, is that still the outcome measure used only, or has it changed?
Yeah, no, it's very much this modified Japanese Orthopedic Association scale is a simple 18-point assessment of their arms, hands, bladder, this kind of stuff. And it sort of triages them into sort of a milder disability as opposed to a moderate severe, because what you're alluding to is the fact that the disease trajectory is quite variable.
Mm.
We think it's probably quite slow at the beginning and then gradually picks up speed, but how fast that is, individual to individual, varies. And all we know is that the more severe the disease, the more disabled somebody is, the faster it generally progresses. And so we're typically at the moment reserving surgery for people in that sort of moderate or severe category, or certainly somebody that we're seeing get worse. And the reason for that is that surgery has risk. About 20% of people will suffer adverse events with their surgery.
Oh, wow.
Many of them recoverable, but they are
Mm.
setbacks. And we don't want to put that's not an easy prophylactic treatment. It's not like handing out a blood pressure tablet. There are
Mm.
real side effects. We can make people worse. So that's the real challenge. And one of the frontiers is trying to get certainty on who needs that surgery at a much earlier stage, which I think needs to come in parallel. And hopefully is being worked on. But yeah, that trying to move that treatment paradigm earlier can make a big
Mm.
difference.
Absolutely. Okay. So if we take the example, we've got, I don't know, 60-year-old Jeff, who, as you said, has with some neck pain, but also there's looking clumsy with his hands, starting to wobble on his feet. The signs are there. The person has hopefully picked up on it early, as you said. They go through the assessment process. They've been scanned, some changes there, and we can reason that it's myelopathy is the issue. We've got Jeff in front of us. We need to tell Jeff that he's got myelopathy. We tell him, and he says, "What's that?" What should we tell him?
So I think this is a big challenge, and it's one of the reasons I'm really delighted to be on this podcast, and I think the efforts you're going to are really, really great. So um, I was on a webinar with some guys from the States, and they talked about these patients being clinic crashers, because you're hoping you have about 50 minutes per patient, and suddenly you've got to suddenly get across to somebody what this disease is, bring them up to speed, enter a conversation around treatment. It's an hour long thing.
Mm.
But that investment's really worth it, because if you get it wrong, then the patients aren't up to speed. They can't make good decisions for them, and lots of problems therefore follow. So I think you've got to take the time to really get across what this is. We've done a bit of work, and I'd like to advertise the charity we set up, Myelopathy, because I think this education, shared decision-making process is really critical in this condition in particular, where there's so much optionality in what we do
Okay.
and when we do it. And I think whenever that's the scenario, the patient's got to be engaged in the decision making to get the best benefits from it. So I think the starting point, as you say, is let them understand what they have. And it's not just about making sure they understand the disease, it's being giving them confidence that we are confident that they have it.
Okay.
So the first one of the big things I like to do is show the MRI scan because I think it's a very visual representation of what's going on. This is your spinal cord, and unfortunately, it's being injured because it's being compressed. I think that's a key thing to get across. People then often ask a little bit about why is it being compressed, and I think the key thing is it's sort of wear and tear. I wouldn't get too much into detail of a disc, a bone, or all this thing. So the spinal cord has got this progression, and spinal cord injury is quite a good buzzword to use because people recognize that, and I like that idea of a slow motion spinal cord injury. And I think that's the key thing to get across because once you've explained that and they understand what's happening, they can see it, they can sort of feel it if you like, and you understand that spinal cord is a junction box between brain and body, therefore the whole body can be affected. They can start to understand and unpick, okay, that's why my hands aren't working, bladder's not working, all of this kind of thing. And the idea it's sort of progressive as well is important because they'll have been feeling themselves getting worse. I think that's some of the key things to get across. But I do like to use the MRI scan because I think it really focuses people onto what they're looking at.
Yeah, some people are visual learners, aren't they? They'll probably remember that more than say all the words we come out with.
Yeah,
That they can
yeah.
keep that picture in their head.
And I
Uh,
think that's a key point. I mean, I think going back to sort of me waxing on a little bit as well, it's
yeah.
exactly the same challenge. I've got a lot of information I can give. What is the information that's going to be very useful to this individual?
Mm,
And one of the things that we've done with the charity is try to develop this thing called a core information set, which you can download from the website. But essentially, it's a sort of an agenda of about 8 items, which is meant to help structure a conversation so that you're really giving the patients just the right information, just enough information in this very difficult scenario because of a lack of awareness in this condition, people often come into our clinic rooms with no knowledge. This is the first time this is going to be mentioned. So they'll have been going through a process, seen various people. Other people tend to avoid talking about the disease because they're unfamiliar with it. They don't want to say the wrong thing. So they're just, oh, the surgeons will sort it out. The surgeons will sort it out. And there's often a false expectation around what we can do as well, which has to be broken down. So there's a lot going on there, a
yeah.
lot to take in. And if we can really overwhelm people, and then as I say, because I want to move on to treatment decisions, you can really lose them. So I think taking the time, being very clear with what the condition is the key starting point. And I do think it's worth investing the time in that.
What you said about false expectations and treatment decisions. So let's say Jeff's with its hope come through the scan with Jeff, clarified what he wants to know, made sure he's at least understood. Um, and he's hopefully nodding along and taking in the simple information. He's obviously going to ask, well, what do we do? Um, and let's not make it any extremes, so not extremely severe or extremely mild, somewhere in the middle, but where he's got options. What's the best way to go about the management options conversation for myelopathy?
So I first start introducing them to how we make the decisions so they feel confident that we're doing the right thing for them. I think it comes a little bit back to the mJOA. So I tend to sit them where they are. And so based on that, there's either a scenario conversation where we start with we could watch and wait, or we could do surgery, or some people are moving, actually, no, we're really recommending surgery here.
Yeah.
If we watch and wait, we'll do the following. So that's the first starting point is, am I offering this patient surgery? And then the second point beyond that is the type of surgery, because there's a lot of different types of surgery we can do. And again, it depends on the individual, their wants, their needs, their pattern of disease. And again, engaging them in that is important, I think, to making sure that they get the right experience out of that.
The watch and wait conversations, and people always talk about the watching out for your red flag, so to speak. If this suddenly happens, or come back to us. Um, the kind of signs they should look out for if things were to get worse. Is there a time frame given with that with myelopathies? Is it just watch it forever and see how it goes, or is there a within if it's doesn't nothing change within 10 years, then we could say this will probably be it. Do we add time frame to it at all, or is it just as long as they're living?
I don't think once this has happened, it's going away. So
Mm,
I think I wouldn't say you're out of the woods at any point in that.
okay.
Certainly the milder it remains, the longer it is likely to remain mild. That is true, but the timeframes are unpredictable and who knows. So I'm very much in the camp of two things. But the first is just if you feel you're getting worse, come back. And
Mm,
that's a really difficult one because there's two scenarios there. There's the sensitivity of that feeling that that it doesn't matter if they can't objectively quantify some change or a doctor can't examine them and find the change. If they feel they're getting worse, that's very high pickup rates. I know I'm not going to miss anyone. The
mm,
trade-off is that perhaps you will experience this a lot in the pain world, Ben, is that once somebody knows there's something wrong, their mind is then racing. And there is a group of people who
yeah.
the burden, I think, of the anxiety of what's happening inside them then start to feel worse anyway. And that's a bit more difficult to manage. But at least they're coming back to be seen. And it means that they're not waiting for a fixed time point of 6 months or 9 months. They're coming and they're ringing up and they're coming back at the moment that they're feeling worse, and we can go through things with them again. I
Mm,
think that's the first thing. The second thing that cropped up, which again came through this core information process, where we did a sort of co-produced patients, professionals globally to sort of produce and distill this down, is activity modification. And it's a question that patients ask, which I avoid because, to be honest, there is no good information around that. But interestingly, coming from the States,
yeah.
which has an equally litigious environment as the UK,
Mm,
they're under a lot of pressure now to talk to people about modifying their risk of falls. Because there is
mm,
this very rare association. If you've got narrowing in the neck around your spinal cord and you have a sudden jolt, you can suffer a spinal cord injury because your spinal cord's got nowhere to go. The risk is, if you look at the numbers, is probably only twice that of having a traumatic spinal cord injury. So it's an incredibly rare event. But at the same time, there is this move now in the States. If you haven't documented or said that you've told somebody to think about that, then
mm,
they have a liability risk. And it comes, and then the question is, what do you actually tell them? And that's really difficult because we don't know, oh, you shouldn't do that activity, but you could do that one or whatever. But I think it just comes into having had a sensible discussion that they need to think about risk modification. And normally we're talking about high energy activities, so sports like skiing or
okay.
things where there's you might have a sudden fall. But the irony of it is when I see people who've suffered that spinal cord injury as a result of narrowing in their neck, often the falls are quite innocuous. They've just tripped on the street
Mm,
or something. So I don't know how modifiable that risk is, to be truly honest. But there has been a push, I say, from
mm.
our partners in the States that it should at least be mentioned, and I think that's not unreasonable. But it can
No.
burden the patient with the anxiety of what on earth they do next.
Oh yeah, I'm thinking of that second group of patients you were talking about, with the potentially that kind of the diagnosis kind of takes over and the label of it. And if you add in the fear of, oh, if I fall over, what could happen? Yes. I don't know the easiest way to, because it's one of those things where you have to tell them, but you don't want to make it sound scary at the same time.
Yeah. And then I think the conversation then has to come into, what can we do about it? Because then they need to really buy into the risk profile of the surgery. Because, there is that it's rare, but people can be worse off after their surgery than they were to start with. So it's a tricky one. I can remember one of the ladies sticks out in my mind, particularly she was quite young. I think she was in her late 30s, and
Mm,
she had this very, very impressively large disc slip on her scan. So, but she was very mildly affected. And to be honest, when I kept seeing her, things were broadly the same, but I could see mentally she was tying herself in knots.
mm,
And in the end, I think actually she had some joint care in her. She ended up having operations somewhere else, but at least that sort of got her through that, and she was fine in the end. But it's a difficult one, and I think it's this. We've got this parallel push in research because there's nothing more difficult than dealing with uncertainty in decision making because
yeah,
you don't want to force people to do the wrong thing,
yeah,
because you have to live. Everyone's got to live with that. But and I think the more we can do to help understand who needs the surgery, the risk benefits of that conversation, I think it's really important. And I think it's one of the exciting areas in this space anyway for AI, because really
yeah.
it's a prediction engine. You give it more
Ah,
data, different data. It should be able to help us tailor these conversations. And there's the some partners in Norway have
Mm.
got Norway's an interesting country because it's very wealthy, it's quite small, it's very well connected healthcare system.
Okay.
So it's very joined up, all the data's very joined up. And they have now this platform for their spinal surgeons piloting where they have all the patients who've ever been treated before is data in there and there's a model and it takes certain characteristics of the patient in front of them and sort of presents them, look, if we do surgery now, this is what we expect to happen to you. And it's still
Oh,
crude. It's still crude, but it's a lot better than me going, yeah, you're sort of moderate disability and on average this, on average that, because yeah, it's different. It's difficult.
oh, that's more personal, isn't it? Because it's
Yeah.
using their data and people like them. I presume the clinician can still overrule it?
Yeah, I think and I think that's, going on different direction. But data's imperfect, isn't it? Because it's we look at averages, but ultimately there are outliers to any
Of
any any
course.
set of data. But I think it's just another useful tool, and the way they display it on the screen, these sorts of color code things, and really
Mm.
trying to gauge the individual in, look, this is what could happen to your neck pain. This is what could happen to your walking imbalance. This is the risks of something going wrong, but these are the risks. This is the proportion of risks that actually um, would lead to being worse. So all of that comes in, and you how people manage and interpret that data, I think is different individual to individual. But I think particularly in a more educated society, I think people do like seeing those numbers and being able to think about them.
Of course. Could it, if you are going to lift someone for surgery, could that data be used to help them almost, I don't want to say persuade, but influence them to become fitter for surgery? In a way, if they can reduce their risks of the side effects and downsides afterwards, if they see that on a visual.
Yeah, maybe smoking. I don't think that's covered in this Norwegian data set, but it's a great question. I mean, I think one of the interesting areas for us as a condition is we're elective surgery. So we're semi-urgent, but we're still elective.
Mm.
And that opportunity to prehabilitate going into surgery, I think, is an opportunity to optimize our surgical outcomes for sure. And it's something that's sort of gradually being looked at, but we don't really know the implications of that. We sort of tell people to stop smoking and do a few things, but I mean, who knows? But I think certainly if you think about things like vascular surgery, where there is a exercise, certainly helps people come through things like avoiding more ischemia with the surgery and this kind of stuff. It would make sense that there is definitely dividends there.
Yeah. So if onto surgery, so let's say someone is listed or they're very keen for it. What should we set expectations long term? You were saying earlier about obviously it's to stop it getting any worse, but if they ask, will it resolve anything? What should we say?
So the data would say that 80% are the same or better off.
Okay.
20%, unfortunately, will be slightly worse off. The people who are the same better off, about two-thirds, will get an improvement. To be honest, I think this comes back to a big theme around communication. It's all about expectation management, isn't it? And I
Yeah.
think that the challenge here is in general, professionally, we want to lower expectations because that generally gives more dividends when it's better than that or is the same.
Yeah.
But I think the challenge is not to extinguish hope, and recognize that nothing's obviously set in stone. So I generally say that we we don't expect you to get back to normality, or it's very, very unlikely. Something on that. I'm pretty despondent about that. That's pretty unusual, unless they're at a very, very mild end, where in which case, we've got a chance of them being. But generally speaking, I'm pretty negative about that. What I tend to talk about is the fact that there's a good chance that we can make you better than you are. I can't tell you what's going to be better. I can just tell you that the majority of patients report feeling better than they did before the surgery. And it's sort of a bit grey and loose, really. But I think the key crux of the matter is that we're trying to stop this getting worse because ultimately, left alone, this puts people in wheelchairs and things, and so we're trying to avoid total paralysis. So it's a rock and a hard place to some degree. So I think the projections and recovery, particularly in the more advanced stages, are not so relevant to the conversation as that key thing about what's going to happen if we don't do surgery.
Okay. And if they don't, if surgery is not offered at the time and it's a kind of a watch and wait, is it that often people might take the message that this will get worse? Um, is that very much the right thing to say? Or what?
Yeah, it's tricky. I mean, as I said, it's just two different phenotypes. There's the very mild people, in which case the future is quite uncertain.
Okay.
In that we don't think this is going to go away, but it can certainly remain very minimally affected for years, perhaps decades. Um, and then there are people who are in the sort of more progressive, moderate severe. Once people are progressing or they're in the more severe group, we just expect this to accelerate away. And we normally talk about, well, I talk a little bit about, what's happened to you in the last 3 months is probably going to happen to you in the next 3 months.
Mm.
So, if you're getting worse coming into my clinic room, I'm expecting you to continue getting worse going out of this clinic room unless we offer you some surgery. Um, the mild patients are very different because, as I say, that future is different. They probably, some people have had 5 years of symptoms coming into the clinic. Okay, so they might have another 5 years a bit the same. That's quite a long horizon. And then there are the other sort of factors where we need to weigh up the risks of surgery because some of these patients are very frail and old, and it's, their life expectancy might only be a few years. And then actually to put them up front with all the risks of surgery, is that really going to make a big difference to their
Mm.
life? So understanding those sorts of contextual factors as well is really important.
Of course, of course. If they were to have surgery, you said about 80% will feel the same or better. In the long terms, we're talking or decades after they have it, um, they ask, will this come back? Or, is there going to be any
Mm.
long-term downfall from this? Because sometimes you hear about, after surgery, then it starts to affect other levels and stuff like that. Again, if they ask, what should we say?
The answer is yes, it could.
Okay.
And they need to be wary of that. And I think as professionals, we find it very difficult to pick up recurrent disease because, we're used to distinguishing healthy versus from
Mm.
unhealthy. And what you're dealing with here is people who are, left disabled, and we're trying to pick up new disability on the background of old disability. It's difficult. One of the interesting things that seems to be coming up now is that the type of surgery can influence to some extent the likelihood of whether it comes back.
Okay.
So it comes down to some of the conversations we need to have at the beginning when we're talking about the types of surgery, and that some surgeries seem to have a lower risk of this coming back at, say, 10 years than others. And I think that's important in making the trade-offs about what to do, but also in educating the individual about, what to look out for. I mean, I think that the mantra still holds. If somebody has recurrent disease and we react quickly enough to it, that's not a problem. But it is that issue that they have recurrent disease. It gets missed, it gets forgotten, and then
Yeah.
they have a second hit. And there's no doubt that this disease is, it's a second hit, and the idea that your body can accommodate a little bit of damage, but you have another damage, and that sort of reserve capacity is gone, and you're going to be more affected by it. I think that's very true here.
Yeah. Okay. Before we get into your hardest conversation, was there anything about whether it's setting expectations, diagnosed, explaining it, or things about myelopathy conversations with patients that you wanted to say that I haven't asked you?
I think my key messages here are, I think this is a condition where patient engagement is really critical. That's what I've learned.
Mm.
It's really about shared decisioning because there's optionality all throughout the process. And the other thing we've learned is that, I'm fairly expert on this condition, but most of the professionals the patients will interact with are not.
Mm.
And so for them to get the best outcomes, they need to be well educated. We had this great GP from Canada who's involved in our charity, and he once told me that, the way I approach health is that the patients are the experts. I'm the
Mm.
facilitator. And I think that's the way he stays atop across a whole breast of things that are ever changing. He's
Mhm.
listening, he's reacting, thinking. And so I take that if we can make the patients more expert, then the whole journey through our care, but also care outside, can be more effective for them.
Did you find, out of interest, do you find, you said about patients being experts and people Google or AI things these days, do many come in knowing in advance or having suspicions that it is, or is it new to them?
Unfortunately, despite our efforts, most people are coming in new.
Oh,
That
really?
is sure. Yeah, I think possibly the literature is just not good enough out there. The terms that they see in their MRI reports aren't very retrievable online. I don't know the gap. I mean, there's certainly some, particularly in Cambridge, recognizing the charity. People are coming in more educated, they've done some reading.
Yeah.
Um, and sometimes to the detriment. I mean, I can remember a lady coming to clinic who'd had her scan, had gone on the charity's website and started to connect the dots. And then she developed this functional neurological disorder. She started to mimic all the symptoms of myelopathy, even though in fact actually she didn't have myelopathy. And then that was really difficult to unpick because again, the education had gone wrong there. But they're outliers. I think in the main, people, unfortunately, still people are coming in a bit cold. Possibly some increasing the awareness, but it's still that consultation where you can really refine the understanding and give the information, because it's the information each patient needs is different depending on their circumstances. And I think that's the challenge for generic educational content online. It's not tailored. And whether or not chatbots and things can make that improvement, I don't know. But at the moment, it's these leaflets. I tried leaflets, don't think they work very well because, the leaflet is not tailored to what that individual needs in that circumstance. And that's why with our core information sheet process, we ended up having a sort of shared agenda, because at least then you've got key themes to discuss, but the conversation's been tailored to the individual circumstances.
Completely agree. Completely agree. Yeah, I often record things on their phone because it's personal to them and that's obviously their data, so they can do with it what they like in theory. It's not some generic handout that they'll just put in the bin afterwards. So I ask everyone this, Ben, and whether it's related to myelopathy or not, what's been one of your hardest clinical conversations?
I think professionally, I find the hardest conversations dealing with young people, children. I think as a parent, I find them much more emotionally charged situations. I think particularly maybe personality and profession become quite hardened and agnostic to a lot of things that we see. But I think breaking bad news in young people is still pretty tough work. And there was a patient I recently treated, unfortunately, a 19-year-old. He was a father, husband, son, and unfortunately he died from very, very bad meningitis. And the conversation, I had to go and tell the family that this was over. And although I've had all the training, I've even taught a little bit at Cambridge Medical School on communication teaching, and I do a lot of breaking bad news. I failed to give it enough time in the steps, and it went horribly wrong. So basically, if I give more context to this scenario, so I'd come onto shift. This looked like a hopeless scenario. We were going to try a procedure to offload some fluid from the brain because it was a last hope. He was young. We needed to try something. But, we had another scan before surgery, did the procedure. It was all hopeless. And the surgery confirmed it was utterly hopeless. This chap, unfortunately, had died. But then when I went to see the family, because I hadn't been involved in the beginning discussions, what I misjudged, the family were nowhere near where I was. So I knew this was curtains going into this procedure, and I was confirming it was curtains. But they had, were still thinking this was reversible, treatable, this was all going to get better. And in misjudging the starting point of that conversation, presenting this news, God, the thing went up. We had one family relative react, violently, breaking things in the room, charging off. We had a lot of hysterics. There's about 8 people in there. It was incredibly emotionally charged, and it was obviously a devastating scenario. But I do think that if I had been more sensitive to where their starting point was, maybe if we'd broken down this conversation to 2 or 3 conversations rather than one, it was avoidable. And sort of watching this descend into utter, I sort of felt quite responsible for that sort of emotional trauma. Although, obviously, in the long run, it's not changed the clinical scenario.
No. Thank you for sharing that, first of all, because it's important. And people, things don't always go to plan, do they? It's,
No,
we go through all the training and the hours
I
of
think so.
stuff, and you teach it,
Absolutely.
we teach it as well. And sometimes at similar things where you think you're from our side, someone's understanding what's going on, and you think we're on the same page, and as you say, it turns out you're not at all.
I know. And I think it's that classic scenario where you're very busy, you're very pressured, you just want to have the conversation, move on, and it's those, you always get caught out on those ones that you forget to do it in, because very often, most of the time, you take a lot of time and it's probably not necessary, but you occasionally get, as I say, like that, you get caught out and you think, oh, should have followed the process.
Well, that's probably why with the Breaking Bad news process, one of the starting points is clarifying what they know or they've already been told. Is that right?
Exactly. And I did ask that question, but I think I just misjudged, their, that they understood he had meningitis, but they didn't really understand that this was probably, irreversibly brain death. And it's that, critical, it's easy to reflect on now and say, God, that's such an obvious thing to clarify. But as I say, I think being slightly uninvolved from the beginning and coming in a bit fresh and, anyway, it was a very emotionally charged meeting, which unfortunately didn't
No.
go very well.
It's, yeah, the perfect storm of various factors, isn't it? Because none of us are
It's
perfect. There'll always
that's
be
true.
days
I,
when you, yeah, just one thing happens after another, and it just, as you say, come boils over.
yeah. Do you
Um,
remember? I don't know. Some of your listeners may. I grew up through medical school watching House,
okay, yes.
and that they always used to joke that the oncologist, I think his name was Wilson or something, would be thanked for giving the most devastating news possible. And I think that's a goal I've always set myself, but rarely been able to achieve.
Although they may, not that we ever really see them afterwards, but they may be mentally thanking you down the line, whether or not
Maybe.
maybe
You're
someone
very kind,
somewhere.
Ben. Maybe not. Hopefully, hopefully I'm not in their nightmares.
I know you're obviously involved in research, and I was on your research gate earlier. It says you've been part of over 200 publications. Is that right?
Yeah, probably is now.
Wow, well
Yeah,
done.
yeah.
Wow.
It's we've done a lot of work. It's been a fertile space because, as I say, little was happening, and we've been able to put ourselves and my dog in the middle. So I can't say it's all me. I'm grateful to a huge team of people, and we've been particularly great to a huge number of medical students at Cambridge. And they're very switched on. They come
Mm,
very productive, autonomous, and you can throw them very loosely framed projects, and then they do some amazing things. And been able to keep some of them in Cambridge as well, as
yeah.
trainees now. So no, been very, very grateful to a huge number of people.
What's the future? What are we looking at downstream for myelopathy, or upstream, sorry, for myelopathy, do you think?
So I think we can end the moderate to severe disability in myelopathy, and the key is to accelerate diagnosis and access treatment earlier. That we can have these difficult conversations, and we can essentially modify people's outcomes in a much more massive way. I think there are some incremental gains to the way we deliver our surgery. We talked about prehab briefly on this
Yeah.
podcast. It's a small, 1% here, 1% there that can probably overall do better with the way we deliver our surgery. And there are certainly some promising regenerative medicine therapies in the
Really?
pipeline in various different ways that I think, again, could hold dividends to people. But fundamentally, if we can just bring treatment further forward, get more people diagnosed, this problem goes away with the treatments that we have today. And I think that's the key call to action and sort of my lifetime mission.
Fine, fine, fine. Um, and so we said about your research. You're on LinkedIn. Any other socials?
No, just LinkedIn at the moment. You
Fine.
can find me amongst many thousands of other Benjamin Davieses,
Really?
or yeah, that's not. It seems to be quite a common name. It turns out. In fact, there are two other people who work in Cambridge with that name, so
Really?
that's quite confusing for our electronic messaging system.
At the
Uh,
hospital?
yeah.
Oh,
So
wow.
fortunately, I think they've now rotated out, but they were both in orthopedics, which
Okay.
meant that yeah, we got a lot of crossed information for sure.
Oh, geez.
But yeah, LinkedIn's probably the best place, or through the charity, myelopathy.org. Yeah.
And was there anything you wanted to cover, sir? I've missed. You wanted to say?
No, I don't think so. I think I would say that no matter your interest, listening to this podcast, no matter what they are, I think as a problem to solve, myelopathy is a very good one, and we've
Mm,
been very grateful to a huge number of people coming forward to give their ideas, thoughts. I think we probably haven't touched about it too much, but it came up perhaps in my example of bad communication. But listening is really important. I think
yeah.
one of the things that we've been able to do very well as a group here in Cambridge is listen to, not dismiss ideas just because we don't immediately agree with them. Listen and so that's what listening to people coming forward with ideas, patients, whoever they are, wherever they are, and work with them to refine them. And I think it's a community effort that's taking myelopathy forward, and pleased to be in the center of it. But we need that community to do bigger. So if you're interested,
Yeah.
have an idea, anything like that, please get in touch.
And I will put the link to myelopathy.org in the description and your LinkedIn as well, so people can find it there and they can obviously contact you as appropriate.
Perfect.
Grand. Ben, thank you very much for your time and your input today. And yeah, thank you.
Thanks, Ben.